Thanks very much, Dr. Gancho, and thank you to the committee for the invitation to speak to you about a subject I'm very passionate about, rejuvenation of the periorbital area, in particular with volume, and I'll cover both synthetic fillers and fat transfer for those who do either of those. These are my disclosures, but I received no support for this presentation or for this meeting. So if we look at the typical ideal concept of beauty in the 20s versus perhaps early 40s, in particular around the eyes, one of the things we begin to see, and perhaps the most prevalent thing, is the beginning of shadowing in the medial supraorbital region and medial infraorbital region that then extends laterally with time. So you see it mostly supromedially and inframedially. And that shadow begins to create a little bit of a tired appearance, both superiorly and inferiorly. You lose the effacement of the upper lid skin coverage, you lose the coverage of the upper lid skin, and you begin to see the infraorbital hollow more. So I'll talk about how we can reverse that. A little more advanced patient on the left side of the image, where probably in the 60s we see even further advanced hollowing of the supraorbital infraorbital region, and perhaps a little bit of brow ptosis, predominantly laterally where there's lack of frontalis insertion, and probably contribution from lack of volume, from decreased volume in the temporal fossa, and inferiorly as well. But again, you see more exposure. If this had more flash, you would see more exposure of the upper lid. Some dermatochlesis, of course, and result in excess of skin, but to me, again, predominantly we see volume loss. Schematically, the lower lid, at least, you get this double contour deformity where the lower lid fat is pseudoherniated because of a weakened septum, but it's also contributed to by volume loss, of course, in the mid-face, where you have bony and soft tissue volume loss, and then the orbicularis retaining ligament, as we'll show later, helps to contribute to that sulcus there, and then the tear trough ligament, as we'll show more medially. So here are the ligaments then. The orbicularis retaining ligament and the zygomatic cutaneous ligament fuse together to form the tear trough ligament medially, and again the orbicularis retaining ligament creates the majority of the sort of tear trough and tear trough ligament more medially, but the majority of the infraorbital hollow is reflected by that ligament, or caused by that ligament. The zygomatic ligament then contributes to the mid-cheek furrow, which also can be a stubborn area to treat. We have to also consider the bony remodeling that occurs, or bony atrophy that occurs, and that leads to radial expansion of the orbit, predominantly supramedially, so eccentrically supramedially and infralaterally. And that's important because if we don't address that, then we may end up falling for what I think is a bit of an optical illusion, wherein the shadow that gets created beneath the brow makes it look like the brow has dropped more than it really has. So her brow right here is probably no higher than what I prefer to use is the height of the palpebral fissure in order to judge how high the brow should be above the lash line. So as you look across, it looks like she's been brow lifted as we go across here, perhaps twice, in order to create, I think, what the surgeon wants to see is a highlight beneath the brow. But if we think of volume restoration in that area, then we may prevent looking artificially elevated at the end there. The other thing is we're taught to that the ideal brow begins and ends on the bony orbital rim, and of course, if you get this radial expansion of the upper rim, including as well as the lower rim, the upper rim, then you may end up chasing up the forehead in order to get your ideal endpoint of a brow lift. So of course, we wouldn't brow lift this patient any more than we would the other one, perhaps. And again, you see effacement of the upper lid. You don't see much upper lid show at all, and you see actually a parallel line, basically, of the sulcus that we try to create in rejuvenation with the lash line. And the palpebral distance, again, the palpebral height, palpebral fissure height, is about the same as the height of the brow above the lash line. The brow is not higher than that. Another example, same kind of thing. The only thing to keep in mind with the palpebral fissure height guide is any ptosis or any squinting, such as like Renee Zellweger, who had a very squinty smile. So of course you have to account for that. And so if we just, in a blink, look at the picture on the right versus the one on the left, I think the brow looks a little bit higher on her right side. And all I did was reduce the shadow and create more of a highlight beneath the brow, as well as in the infraorbital region. So perhaps she looks more vibrant on the right, and like the brow's been lifted a little bit, but I actually did no elevation of the brow at all in the imaging. So that wasn't my patient, but this one is, where we filled the infraorbital region with a synthetic filler, in this case an HA, which has low hydrophilic properties, and I think this is important in order to prevent post-procedure accumulation of volume. Some people call it swelling, but it's really an accumulation of volume on of water on the product, which can alter your endpoint and make it tough to use a visual endpoint at the end of your treatment for evaluating success. And you may see somebody back 2-4 weeks later and think, what in the heck did I do? That's way more swollen than I feel like I left her. But so that's the reason for using a lowly hydrophilic filler in that area. She could also, of course, benefit from upper lip blepharoplasty, and she later did. So this is an article we published with that patient, actually, which showed about an 85% retention of volume in the infraorbital region at about 14 months. And I can tell you that it actually typically lasts a lot longer than that if you don't already do this type of treatment. In my own eyes, I had it done, and 6.5 years later, I had about, certainly I had some retention of effect, as we showed with 3D imaging, comparing my baseline to that 6.5-year point. It's been another 5 years since then. So very durable, and as we'll show, it's durable in the supraorbital rim as well, although I haven't done a study yet to show that. To me, it's not necessary. Cannulas have become very important to me to use in the periorbital region, particularly the 27 gauge in the infraorbital region. I'm comfortable with that. Others recommend starting with the 22 gauge, and I would agree that that's probably erring on the side of caution. But for reducing bruising as well as reducing the chance of intravascular injection, I think that they're great. 25 gauge I use pretty much everywhere else. I don't use needles that much anymore except for filling little fine lines, such as in the upper lip. I rarely use them around the periorbital region at all. I can't remember the last time I did. Occasionally I'll use a needle for injection of hyaluronidase for subtly reducing either my own or someone else's a little bit overfilling or Tyndall effect, but there again, I'm usually using a cannula for that. So a typical younger patient, I would say, but so not at all uncommon for a patient that presents for infraorbital rejuvenation, doesn't want surgery. And so just to show, we kind of measure the distance that we think we need from the medial acanthus, make the insertion site. In this case, instead of using a 27 gauge cannula, I'm using a 25 gauge needle to make a little bit more of a little bit bigger target in the skin. And then we fill only on back traction, very small amounts per pass. I probably only do 0.01 per pass. And I try to start deep and then work superficially, of course, to try to minimize the chance of a Tyndall effect. If I can't get the result deeply, then I'll just go more superficially, and that way we know if they get Tyndall effect that they can't cover with makeup or bothers them without makeup, then we can just reduce that with hyaluronidase a little bit, keep the majority of the effect, and they're happy. Most of the time it's not necessary, so most of it I address from this infraorbital approach. You can see we've already done the other side, and I believe that's, so about a mid-pupillary line, that vertical line, or maybe just a little bit laterally I start, certainly below the zygomatic ligament or mid-cheek furrow, which is about there. So I start with that one, and I get most of it that I can from there, including laterally. So if they'll tolerate it, and not everybody does, then I'll try to address this lateral infraorbital rim from that more medial access point as well, just to minimize the chance of bruising by another needle site in the lateral canthal region. So she's been very nice to tolerate that well. And then lastly, this has become important for me to fine-tune the results in the transition between the lower lid and the cheek or tear trough area. What I'll do is I'll go with this third site right in the medial aspect of the malar mound, and I think that guides me right into the tear trough ligament area. I try to keep the cannula facing, the port facing downward to minimize the Tyndall effect, if any. And then just that last little transition, so you can kind of see in this, there's that last little area that I wasn't able to quite get from the inferior approach, and that I do feel like I'm more able to get from this approach. So we just do the video there once more, please. So you can see we're kind of judging where the tip of the cannula is, right near the medial acanthus, and of course we want to avoid the angular vessel, which is more medial than that. In this case, it's with Restylane, so that's the most common one that I'll use in this area. So we don't need to show this video, it's just blending into the cheek with anything left over, but as we can see, Well, I was just about finished with that syringe. There you go. So I was just about to finish with that syringe anyway, even on this young patient. So I'm usually getting into a second syringe on most patients. So she's happy. That's immediately afterwards. Sorry, that's not a long-term follow-up, but I'll have some a little bit later. So then moving to the superiorbital rim, and again, looks like the brow may have been elevated a little bit, but just that highlight I think is nice to create the illusion of that, and filling to create that double parallel line, as some say, between the lash line and the reflection of the subbrow skin in the sulcus. So this is a patient who just had her right side, so the left side of the screen treated, and it's immediately after just the right side. And so you can see that parallel line along the lash line compared to the opposite side, where we begin to see what some call a 40s furrow. What I tend to think of as a 40s furrow tends to occur in the begin in the 40s, as we saw with Angelina, and some also call it an A-frame deformity. And there she is the next day after finishing the left side as well. So this is immediately afterwards, but or one day afterwards, but we'll show some longer-term follow-up, but not that much swelling. I think the upper lid is actually more forgiving than the lower lid. The skin's a little thicker, and because there's less light in that area, it just tends to be more forgiving. So I would encourage those who haven't tried that to do so. Blending it then into the temples, this patient had pretty nice highlights everywhere, nice volume, but she has a fairly high forehead, and so filling the temple was helpful. And there she's filled on just her right side, shows the residual shadow in the left side, and then after filling both sides, I think that creates a more harmonious appearance, and that may even lift the tail of the brow a little bit. So there's another patient who's typically presents to us for periorbital rejuvenation, and maybe she's in her 30s. She really doesn't have that 40s furrow. She's got pretty good highlight in the superior and inferior orbital regions. Maybe she could use a little bit of lateral canthal filling and maybe a little temple filling. But actually, that's somebody I'd already treated, and so I think in doing that, it just kind of drives home to me anyway the difference that you see, and on sort of a blink phenomenon in this patient, this side looks just more sad, hollow, maybe even depressed, but certainly more aged than the other side, which looks more vibrant and youthful. So she was very happy with that, and there she is with. I show this to remind me to recommend doing non-flash photography, at least from the front view, at least one of them. Try to train your staff to do that, because if you don't and you use flash for everything, you'll rob yourself of the ability to see the contours that the shadow can create with just overhead lighting. So, and then with flash at the far right there, of course. And then here she is. I just saw her a few months ago. She's 3 years out, actually, and you see pretty good maintenance of effect in that supraorbital region with effacement of the upper lid still. So she's thrilled. So in summary, HA fillers are very helpful for this area. They're safe, they're reversible, inject only on withdrawal. I like using cannulas, as I mentioned, typically 27 or 25, and make sure you know where the neurovascular foramina are and stay superficial to those. So transitioning then over to fat transfer. Fat has several advantages over synthetic fillers in that it's natural, of course, not just naturally occurring, but natural to the patient. It's durable, and there's no chance of Tyndall effect. So even though I do probably 350 synthetic filler cases in the periorbital region a year, occasionally we get a little Tyndall effect, and it's not a huge deal. You can reduce it with hyaluronidase, but one of the advantages of fat transfer is that you don't have to do that. There's a possible stem cell effect, as we'll talk a little bit more later. It's easily combined with other procedures, as we'll show, other surgical procedures. The equipment is very inexpensive. It's one of the best ROIs that I've realized in practice, except for maybe a blade handle. And the satisfaction is overall quite high, as long as you discuss appropriately ahead of time what the predictability is, and the fact that there is variability. So disadvantages, the downtime, it can be a second week instead of a lot of surgical procedures is mainly a week to 10 days, and some see differences even over the course of a month. So patients have to be prepared for that and know that hopefully that'll be the last time they have to do that for quite some time. The predictability does vary, or is imperfect, and about 32% retention has been shown in a long-term study with a decent range. But regardless, in our practice, it's probably a 5% touch-up rate combined with patients that just want a little filler to touch it up after a round of fat transfer. You have to be aware that in thin patients, it's tougher to get a good result. Older patients, the fat may not take quite as well. And if the weight is fluctuating, then the fat that you transfer to the face will fluctuate as well. because it is durable, you don't want to overfill. And just like with synthetic fillers, you have to be aware of intravascular injection and avoid that, of course. So I won't go too much into the detail of the technique. It's not a brand new technique by any means, but gentle handling, centrifugation. We are adding PRP now in a ratio about 1 to 10, and we use 1 cc syringes for the infiltration, 0.9 and 1.2 millimeter cannulae. I'm mainly only using the 0.9 for the superficial infraorbital rim, and everything else the 1.2 millimeter cannula. As a reference, that's still larger than a 22 gauge needle, which some recommend, or cannula that some recommend for synthetic fillers. We inject in multiple planes in small amounts for maximum vascular ingrowth, of course. It's only about 0.1 cc per 3 to 5 passes we'll show in order to minimize chance of irregularities. And patients always ask, what about irregularities? And it's just really uncommon. I can't say it's 100% not going to happen, but it's really, really uncommon and usually easily treated in the rare instance that it happens with a little steroid. So injectable ammo withdrawal, of course, in key areas. In the periorbital region, these are the typical markings, and won't belabor that too much. Can you play the video, please? So we palpate the infraorbital rim just to protect it and feel where the cannula is at the infraorbital rim and feel it going over the infraorbital rim. Say just above the rim and extend laterally. Supraorbital rim medially, basically we start at about the midpupillary line area to address the more medial aspect, protect with our non-dominant hand, and then laterally we begin at about the lateral canthal region and infiltrate, laterally blending into the temple. So just some quick examples of different degrees of atrophy and what we've used, the volumes that we've used to treat that in order to get results that I'm pleased with and the patients seem to like as well. 1 cc with this technique anyway, 1 cc in each of the medial-lateral deep infraorbital rim and 1 superficial, blending it with a little bit in the anterior and lateral cheek, 3 and 2, a little bit in the lateral canthus. 3/4 view. She was at least as happy with her mid-face improvement as she was with her facelift that she also had. Another patient with a little bit more atrophy, and in addition to the 3 along the infraorbital rim, we did a couple in the supraorbital rim. This was coupled with an upper blepharoplasty, and she was very happy with that. We did not use do a lower blepharoplasty in this patient. And then more advanced atrophy, for whom, in a patient for whom we put twice as much in the superficial infraorbital rim, and we actually used 4 in the supraorbital rim to efface the upper lid and try to create that double parallel line with a lash line. And we got some brow elevation laterally with that through what I think is like a pendulum effect. And guys, we just have to be more conservative and minimize the chance of overfilling, creating a feminine appearance, unless that's their goal. And so 3 cc's inferior, nothing in the anterior and lateral cheeks, coupled with a lower blepharoplasty, same type of idea, but we did do just a little bit in the anterior and lateral cheek, 1/3 as much as we would do in a woman. So, and I'm glad we didn't do any more. I think that created a nice improvement without feminization. So in the future, what kind of enhancements? We already mentioned that I'm starting to use PRP. Actually been doing it for about a year or two, and certainly haven't seen any excess effect with that. We're using a ratio about 1 to 10. Maybe there's a little decreased bruising and some increased retention. It certainly isn't harmful. Stem cells in an animal model has shown increased increased dermal thickness through new collagen formation in the skin under which fat was placed. In a murine model, and Tenard has shown improvement in skin texture with what he calls nanofat, basically emulsified fat that's been filtered, and I look forward to seeing more from that, but I don't know that that's going to replace the volume effect that we get with the what some call macro fat that was described earlier. So in summary, volume loss occurs in the periorbital region. I think it's very gratifying to treat it, whether you use synthetic fillers or fat transfer. Either medium is very nice to create what you try to create as a masterpiece. Thank you.